Hello, dear friends. Today we will discuss about some of the multiple choice questions of autonomic nervous system, and I will give you the explanation of the correct answer also. So first one is all of the following organophosphates are highly lipid soluble except, and the options are diphlose, ecothiophate, malathion and diazinone. Now generally we feel that organophosphate compounds, they are definitely highly lipid soluble, and that's why they are practically absorbed from the each and every root, and that's why the chances of poisoning will be there. So why there is a question of except? But yes, there is an exception, and that is ecothiophate. It is a highly water soluble compound. Okay, so the answer will be ecothiophate. Second is anticholinesterases are contraindicated in, and the options are paralytic ileus, angle closure glaucoma, sick sinus syndrome, and all of the above. Now anticholinesterases, it means that they inhibit the cholinesterase, so they increases the level of acetylcholine. So don't confuse, there are two different terms. One is the anticholinergic agents, these are blocking the effect of acetylcholine, while the anticholinesterases, they inhibit the enzyme cholinesterase, and then because of this they increases the level of acetylcholine, so they are having cholinergic actions. Now the cholinergic agents, we all know that these are the pilocarpine, physostigmine, neostigmine, and through their action on the M3 receptor, they increases the peristalsis, so they can be used in the paralytic ileus. And pilocarpine, it is one of the important drug for the angle closure glaucoma. Then the next is sick sinus syndrome. It means the SN node is not functioning. Now you all know that the vagus, which is a cholinergic involvement, and the vagus is cardio inhibitory. Means when the vagus is stimulated, there is a depression of the SN node. So we cannot give the cholinergic agent in any circumstances in case of person is already having sick sinus syndrome. So the answer is sick sinus syndrome. Then find the incorrect statement. First statement is neostigmine is synthetically derived while physostigmine is naturally derived. Yes, neostigmine is a synthetic compound and physostigmine is naturally occurring alkaloid. Only physostigmine is having direct action on the NM cholinereceptors. Now, there are many differences between the physostigmine and neostigmine, and one of the important differences is neostigmine is having a mainly peripheral action, especially on the skeletal muscle. It is very useful in the myasthenia gravis because in addition to its multiple other action, it can directly stimulate the NM receptor present on the skeletal muscle end plate, and that's why this statement is incorrect. Next is neostigmine is having poor corneal penetration. Yes, because neostigmine is a quaternary ammonium compound. All the quaternary ammonium compounds, they are not or poorly absorbed orally, cannot cross the blood-brain barrier, poor corneal penetration. All these are the characteristic of quaternary ammonium compound. And only physostigmine and not the neostigmine is having the central action. Again, that is a correct statement, as I have told you that the tertiary amine compound like the physostigmine, okay, it can crosses the blood-brain barrier, and that's why it is having CNS action, while the neostigmine, it is a quaternary ammonium compound, it is not having a CNS action. So that is also correct. So incorrect statement is only the second one. Okay. Then the fourth, Which of the following agent is used to differentiate the myasthenic crisis from the cholinergic crisis? Now, myasthenic crisis means that because of the significant we can say the deterioration in the condition, the muscles are significantly weak and paralyzed, while in case of cholinergic crisis, because of the excessive cholinergic activity, again the situation is same like that of myasthenic crisis. So how you can differentiate? So the options are idrophonium, ecothiophat, Icerin and Tacrin. Now the idrophonium. Idrophonium, it is a very rapidly acting, very potent and very short duration of action of anticholinesterase. So if you give this agent in such type of the confusing condition, then if the person is having myasthenic crisis, then the condition will definitely improve. But if the person is having cholinergic crisis, there will be slightly deterioration or the exaggeration of the cholinergic crisis, but it is very transient because idrophonium is having a very short duration of action, and that's why it is used as a diagnostic test to differentiate the myasthenic crisis from cholinergic crisis. So the answer is idrophonium because of its rapid, potent and short duration of action. Which of the following side effect of pilocarpine? It can be observed at high doses only when used topically for open angle glaucoma. Now this is a very one can say the tricky question. You have to read this very carefully because pilocarpine is having many adverse effects when it is given topically, but here it has been specifically mentioned at a high doses. Okay, so and the options are, first we look at the option broache, then bronchospasm, then stinging sensation in the eye and the headache. Now we all know that pilocarpine is used in open angle as well as the angle closure glaucoma because it increases the drainage, because it removes the blockage of the aqueous humor, but it is now not a first line drug because it will lead to the headache, then broache, then initial stinging sensation of the eye. But when you apply the pilocarpine topically, the amount absorbed into the systemic circulation is very negligible to produces the systemic cholinergic action. And if you give pilocarpine in a very high dose for a longer period of the time, then and then the systemic cholinergic action in terms of bronchospasm can be seen. So the answer is bronchospasm. Next is the agent which inhibits the release of acetylcholine from nerve ending. So you know that there is a particular biosynthetic pathway for the acetylcholine, and there are different drugs acts as a different site. Out of this, you have to find out the agent which inhibits the release of acetylcholine, and the options are hemicolinium, then vesamicol, then black widow spider toxin, and then botulinum toxin. Now there are two toxins. There are two toxins which causes the depletion, or we can say that they inhibit the action of the acetylcholine, but two different mechanisms. One is the black widow spider toxin. It causes excessive release of acetylcholine, and that's why there is a depletion of the store, and that's why there is a inhibition of the action. While in case of the botulinum toxin, it inhibits the release of the acetylcholine from the nerve endings. Okay, and that's why the answer is botulinum toxin. Then corticosteroids afford improvement in the myasthenic patients by their, now you all know that myasthenia gravis is an autoimmune disorder, and the improvement, it can be seen with the reversible cholinesterases like neostigmine, pyridostigmine, And corticosteroids are also useful. Okay, we will discuss after just looking at the options. First is the anti-inflammatory action. Yes, corticosteroids are having anti-inflammatory action. Immunosuppressant action. Yes, corticosteroids are having very potent immunosuppressant action. Then by stimulating the NM receptor? No, corticosteroids are not stimulating the NM receptor on the muscle and plate. This is the function of the neostigmine. In all of the above. So here there is a confusion between the first two, potent anti-inflammatory and immunosuppressant. But dear friends, you know that here the question is about the myasthenia gravis, and as it is an autoimmune disease in nature, the immunosuppressant action of the corticosteroid may help in some cases of myasthenia gravis. So the answer is immunosuppressant action. Then therapeutic status of the oximes in organophosphorus poisoning. Now we all know that oximes are the reactivators and they are given after the atropine. So the options that we are looking, that the primary antidote, then adjuvant to the atropine, but atropine is a primary antidote, along with the atropine as a primary antidote, and preferred in cases where atropine is contraindicated. Now we will go in a reverse order, that there is not even a single condition of organophosphorus poisoning in which the atropine is contraindicated and the oximes are helpful. Okay, and that's why this option goes out. Now what is the role of atropine and oxime? One should be clear for that. Now one has to give, obviously OP poisoning is a emergency condition. One have to first look for the airway breathing and circulation, termination of exposure and everything, but after that you have to give the atropine 2 mg intravenously repeatedly, because to block this excessive cholinergic action. And after giving the atropine as a primary antidote, then you have to give oximes. Okay, without giving atropine you cannot give oximes, they are not going to be helpful. Okay, and that's why the answer will be as an adjuvant to the atropine, but atropine is a primary antidote. Now find the correct statement or statements. It means there may be more than one correct statement. Hyoscine produces CNS depressant at any dose. Then second is atropine is having predominant action on the bronchial smooth muscle, while hyoscine is having potent action on the secretory glands. You know that atropine is having some predominant action on certain organs, while the hyoscine is having on the another organ. So this statement is correct. Atropine is having primary action on the bronchi, while the hyoscine is having action on the secretory glands. Then hyoscine is having longer duration as compared to the atropine. No, atropine is having longer duration as compared to the hyoscine. So this is an incorrect statement. Both atropine and hyoscine are derived from the natural sources. Yes, atropine from Atropa belladonna and hyoscine from Hyoscines niger. So hyoscine produces CNS depressant at any dose. Yes, in low dose as well as high dose it produces. So that is correct statement. Third one is the correct. Fourth is correct. So the answer is first, second and fourth. All these are correct except hyoscine is having a shorter duration of action as compared to the atropine. Okay. Now match the followings. Now on the one side there are different conditions and on the another side there are agents. Cardiac vagolytic. You know that the vasovagal shock again is a life-threatening condition, and that's why that can be seen before any stressful or operative procedure, and that's why before any operative procedure we are giving atropine to prevent the vasovagal or to treat the vasovagal shock. Now second is the fundoscopy. In the fundoscopic examination we require only mydriasis and no cycloplasia. Okay, and that's why we require a sympathomimetic agent, because sympathomimetic agent will produce only mydriasis, while the anticholinergic agents that are given tropicamide, atropine and cyclopentolate, they additionally causes cycloplegia, which is not required. Okay, and these mydriasis and cycloplegia is required to check the refractory error. So the next question is this: diagnosis of the refractory error, but in the children. Now in the children, the tone of the ciliary muscle and other ophthalmic muscle are very high, and that's why we require an agent which is having very potent cycloplegic action, and that's why the answer is atropine. And the last is the treatment of corneal ulcer. Again, we require the agent which is having a local anodyne like action on the cornea in addition to the above mentioned action, and that's why the answer will be atropine. Okay, so there are different atropine substitutes, they are having a different actions. Now, which of the following sympathomimetic agents causes rise in systolic, diastolic and mean blood pressure along with the reduction in the heart rate? So there is a rise in all the parameters of the blood pressure as well as reduction in the heart rate. And the options are adrenaline, noradrenaline, isoprenaline and all of the above. Now, you know that the adrenaline is having action on the alpha 1 receptor, beta 1 receptor and beta 2 receptor. Okay, while the noradrenaline is not having action on the beta 2, which is the reason for slight fall in blood pressure in case of adrenaline. So, and the isoprenaline, it is having action on both beta 1 beta 2 receptor. So out of these three agents, the only agent which acts on the receptor which is responsible for the rise in the blood pressure, and the receptors are alpha 1 beta 1, and that agent is noradrenaline. And obviously because of the rise in the blood pressure and because of this homeostatic mechanism, there is a reduction in the heart rate. So the answer is noradrenaline. Release of the catecholamine from the adrenal medulla. You know that the adrenal medulla is a gland, and these release, even though the catecholamine is a sympathetic neurotransmitter, but these release is primarily mediated to the nicotinic receptor, and it is not mediated because of the any adrenergic receptor, that is alpha 1 beta 1 and beta 2. So the answer is the ANN receptors. Okay, one should be very careful by giving the answer of this question. Then out of the following, which is or are selective alpha 1 receptor agonist or agonists? So there can be more than one answer, and many a times it is a misleading also. There can be only one answers, but to mislead you or to deviate you, such type of the questions can be asked. We will first check the options: the prazosin, pyranzapine, phenylephrine and clonidine. Okay, now first we focus on the alpha 1. So pyranzapine, it is acts on the muscarinic receptor, so it goes out. Now the remaining agents are prazosin, phenylephrine and clonidine. Now the clonidine acts on alpha 2 receptor, so it again goes out. Now the two, prazosin and phenylephrine, both acts on the alpha 1 receptor, but prazosin is a selective alpha 1 blocker while the phenylephrine is agonist. So the answer is phenylephrine. Then which of the anti-glaucoma agent acts by increasing the trabecular outflow? And the options are timolol, dipivaprin, brimonidine and acetazolamide. Now to give the answer of this question, you should have a very clear vision or knowledge about the trabecular outflow pathway anatomy of the eye, okay, and the site of the action of the different agents, and then you can give the answer. So increasing the trabecular outflow is a function of the adrenaline, but it is not used, but the product of the adrenaline, that is dipivaprin, is used. So the answer is dipivaprin. Most rapid lowering intraocular pressure in acute congestive glaucoma is achieved with intravenous pilocarpine, intravenous hypertonic mannitol, intravenous acetazolamide, and topical beta blocker. Now, you all know that acute congestive glaucoma is a really a life-threatening emergency condition because of there is a sudden rise in intraocular pressure, and you have to control the intraocular pressure to prevent the visual loss. Okay, and the most rapid action is seen with, even though the pilocarpine, acetazolamide, beta blockers are used, but we are giving a hypertonic solution of the by the intravenous route, then that is mannitol. It will immediately reduces the intraocular pressure. So the answer is intravenous hypertonic mannitol. Then select the correct sequence. First is the most rapid, then slower, and then the slowest of the onset of alpha 1 receptor blocking activity. So most rapid to most slow. And the options are phentolamine, then prazosin, then phenoxybenzamine, then phentolamine followed by prazosin, and prazosin similar to the phenoxybenzamine, and then phenoxybenzamine, prazosin, and phentolamine, and lastly prazosin, phentolamine, and phenoxybenzamine. So now when you have to attend the such type of the question, you have to remove one by one option. Now the most rapid one, now you all know that phentolamine is used for the diagnosis of the pheochromocytoma because it is having a very rapid onset of action. Okay, and that's why the first should be, because you have to write from most rapid to most slow. So the phentolamine. So obviously the last two options will go out. Now there is a query between the first and the second. Now you just look carefully that phenoxybenzamine. Phenoxybenzamine is used for the management of the inoperable cases of pheochromocytoma because it requires time for the activation and then it produces the action and then its effects last longer, which is not there in case of prazosin. And that's why the correct answer is the most rapid is phentolamine followed by prazosin followed by phenoxybenzamine. Then following smooth muscle tones are increased through stimulation of M3 receptors except. Now the M3 receptors, they are present on the visceral smooth muscle, and when these muscles are stimulated there is an increased contraction or increased tone, but here it has been asked except. So we will first see the we are just see the different options. First bronchi, then the another option we are looking, that is detrusor muscle of bladder, ureter, and bladder tricone. Okay, now apparently it feels that okay, there is some problem in the question because all are the smooth muscles and the whole M3 receptor is present and these are contracted. But if you look carefully in the bladder trigone, even though it is a smooth muscle, but the alpha 1 action is more prominent. Okay, and the M3 receptor, normally what will happen, because of the when the cholinergic system is stimulated, there is an increased tone of the smooth muscles of the detrusor muscle of the bladder, and at the same time there is a relaxation of the bladder trigone, and because of this there is a urination. So here the answer is bladder trigone. Next, yes, you have to match the following drugs. Here the word source is incorrect. Okay, non-selective beta blocker with intrinsic sympathomimetic activity. So here you have to just remove the cardioselective agents. Okay, and Again in the non-selective, you have to find out the agents which is having intrinsic sympathomimetic activity, and these are pindolol is the correct answer for this. Okay, because the propranolol, sotalol and timolol, these are the three agents which are not having intrinsic sympathomimetic activity, and the pindolol is having, so that is the answer. Then beta blocker with class 3 anti-arrhythmic property, and the answer is sotalol. Sotalol is having class 3 anti-arrhythmic action. Then cardioselective beta blocker, it means that the agent which is acting on the beta 1 receptor but additional beta 2 receptor agonistic action, that is seen in case of acebutolol. Now nebivolol also causes vasodilatation, but that is because of nitric oxide donation. Okay, and lastly the ultra short acting beta blocker devoid of membrane stabilizing action. This is the most easy because ultra short acting beta blocker, that is only one, and that is used in hypertensive emergency. So here you have to remember the E, hypertensive emergency E, and the agent is esmolol, that is E. And why it is having a very short plasma half-life? Because it is immediately destroyed by the esterases, again E. So the answer is esmolol. Okay. For giving the answer of this question, you should thoroughly know the detailed classification and characteristic of each of the beta blockers. Following are the advantages of cardioselective beta blockers except. Now first we will see the options. Lower incidence of cold hand and feet. Now these effect is mediated through beta 2 receptor, and that's why these advantages can be seen. Less liable to impair the exercise tolerance. Lower propensity to cause bronchoconstriction. Yes, right, because again the bronchoconstriction is through the beta 2 receptor. Less deleterious effect on the lipid profile. Again the metabolic effect mediated through the beta 2 receptor. But on the skeletal muscles also and the blood vessels supplying the skeletal muscles, the beta 2 receptors are present. But dear friends, there are two terms. One is the exercise tolerance and second is the exercise capacity. Exercise capacity depends on the functioning capability of the skeletal muscle, and that depends on the blood supply to the skeletal muscle, and that is through the beta 2 receptor. So when you block the beta 2 receptor, what will happen? That normally the beta 2 causes vasodilatation, so beta 2 blockage causes vasoconstriction, and that's why the exercise capacity is reduced. Okay, but here the point is different, and that point is less liable to impair the exercise tolerance. Now what do you mean by the exercise tolerance? Tolerance means person is able to tolerate the exercise, and that is depends on, means when you are doing the more exercise there will be more need of the blood, and that's why there is a more cardiac contraction, and after some time person is not able to cope up this increased demand. So that is exercise tolerance. Now exercise tolerance less liable to impair the exercise tolerance, that is not correct, and that's why if you just look at this, that the lower incidence of the cold hand and the feet, the bronchoconstriction, less deleterious effect on the lipid profile, all these are correct except this second one. Okay, which of the following anorectic agent is banned because of the increase in suicidal tendency? Now you know that previously there is a phenylpropranolamine, then sibutramine, rimonabant. All these are the agents but these are banned because of some reason. Here the reason that has been already told, that is suicidal tendency. Phenylpropanolamine, sibutramine, rimonabant and all of the above. All these are banned, but only the rimonabant is because of the increased suicidal tendency. Then which of the following agents act directly as well as indirectly? Okay, so here you have to give the answer, the sympathomimetic agent which is mixed acting. That is methoxamine, then tyramine, then ephedrine, and then all of the above. And the answer is ephedrine because it acts through both directly as well as indirectly. Tyramine is indirectly acting, methoxamine is directly acting, while the ephedrine is mixed, both directly as well as indirectly. Now, which of the following uroselective alpha blocker is not having apoptosis promoting effect on the prostate? Okay, now first of all you have to find out the uroselective alpha blocker. First we see the option. Prazosin, it is not a uroselective. Terazosin, yes, it is uroselective. Doxazosin, yes, it is uroselective. And tamsulosin, again it is a uroselective. So last three are the uroselective, but only the terazosin and doxazosin is having apoptosis promoting action, but that is not seen with the tamsulosin. So the answer is tamsulosin. Therapeutic status of beta blocker in CCF. A couple of years back, the beta blockers were contraindicated in the CCF, but now it has been found that the disease progression is because of the excessive sympathomimetic activity. Okay, and that's why beta blockers are helpful to prevent the disease progression if given early in the disease, but they are not, or they must not be given in the decompensated cases. Okay, so the drug of choice for all stages of the CCF? No, incorrect. Preferred in the terminal stages of the decompensated? No, they are not preferred in the terminal stages. Contraindicated in CCF? Again no. So preferred in the compensated? Yes. And contraindicated in decompensated? Again yes. Now why they are contraindicated in decompensated? Because in decompensation the person is living just because of some of the cardiac contraction, and that because of that some amount of the cardiac functioning the person is able to survive. And when you give the beta blocker, that last hope will be lost, and that's why the correct answer is the last one, preferred in compensated but contraindicated in decompensated. Which dilution of adrenaline is used to control the local bleeding in case of epistaxis by topical application? We all know that the adrenaline, because of the alpha 1 receptor agonistic action, it will constrict the blood vessels. And in the epistaxis, when you just apply the auspice soaked in the adrenaline solution, it can helpful to arrest the bleeding, because the nose there is a very rich blood supply. Okay, but what is the solution? Okay, 1 raised to 1000, 1 raised to 10,000, 1 raised to 1 lakh, or 1 raised to 2 lakh? The answer is 1 raised to 10,000. Therapeutic status of pilocarpine in open angle glaucoma is? It is an alternative to beta blocker? No, it is not an alternative, because there are many side effects. One cannot be used as an interchangeably. Second line agents after failure of prostaglandin analogs? No, even it is not preferred as a second line, because prostaglandin analogs, then beta blockers, and if all these agents are not effective or contraindicated because of some reason, then we can go for the pilocarpine because of the shorter duration of action, fluctuating intraocular pressure, and many side effects. So the third line agents, in case of failure of all these first line agents, that is the correct answer. And contraindicated? Obviously no, they are not contraindicated. So this is the answer. Principal mode of termination of action of adrenaline. It's a very simple question. The action of the adrenaline is terminated because of its reuptake, and that is axonal reuptake. So we just look at the option first. Ideally we should do this: degradation by MAO, degradation by COMT, axonal reuptake and extraneuronal reuptake. So the answer is axonal reuptake. Don't confuse with the extraneuronal uptake, even though the some amount is uptake by the extraneuronal side, but this is not the principal mode of termination. Okay. AV nodal conduction delay is primarily mediated through which of the cholinergic receptors? Okay. M1, M2, M3 and NM. So there is a no scope of NM. So there is a selection between M1, M2 and M3, and the answer is M2. M1 is present on the CNS and gastric glands, M2 on the heart, M3 on the visceral smooth muscle and secretory glands. So you have to remember like these, and that's why the answer is M2 receptors. Okay. So this is all about the discussion of these MCQs of autonomic nervous system. Please give your comment in the comment box, your some feedback. Whatever will be your feedback, feel free to share. And if yet you have not subscribed, please subscribe to this channel, Pharmacology in Simplified Way by Dr. Darshan Dave. Okay. Thank you very much.